Good afternoon. Hi, everyone. Welcome to the abstract session for ventral hernias. We're very excited to have all of you here today. My name is Dr. Anna Higgins. I'm a MIS hernia surgeon at the Medical College of Wisconsin in Milwaukee. Excited to have you all here, and I'll have my colleague here introduce herself as well, and then we'll get started.
Hi, everybody. My name is Wenwei Tan. I'm also a minimally invasive surgeon at the Medical College of Wisconsin. Thanks, everybody, for coming out today. Our first speaker is Dr. Correa, and we'll be talking about abdominal wall closure with a novel suture tension distribution device after oncologic laparotomy.
And this, for all those sitting at tables, there are QR codes in the middle. There are candidates that are going to be selected and nominated for potential best paper awards. So Dr. Correa's abstract is one of those. We'll let you know those abstracts as they come along, but please vote using the QR code in the center of your table. Yeah, go ahead. Of course. Oh, yeah. Are there? Oh, there's no stairs.
No, there's no stairs.
Oh, they didn't want you to hop up. Yep, and the green button. The green button is forward.
Yeah, no, but like for the pointer, for the laser. No? Okay.
Is no laser pointer? Is there a laser? No laser pointer.
I think I can work through it without the laser.
Okay.
That's good.
Great.
So, we're gonna start. Thank you, everyone, for Okay, thank you.
Oh, he's got one.
Oh,
You want one?
yeah, perfect.
Thank you very much.
Thank you. So good afternoon, everyone. My name is Juan Correa. I'm the PI in this incredible study that we did. It's the Rebuild. It's a prospective multi-center single-arm feasibility study using Rebuild an absorbable biabsorbable closure device for the abdominal wall. What I think it's not okay. So the first thing is this is a study that was funded by Absolutions Medic. We have a booth over there, and you can take a look at the device later on and see what how easy it is to handle and the advantages that it has. I know that everyone in this room knows what happens when you have a suture that is very tight, and it increases the tissue stress, and it tears the tissue, and you end up having an incisional wound hernia. I think we've all seen that. We tried multiple techniques. We know about the stitch trial, try to close the distance between those bites that we have, but this tends to happen. And also we can see that it happens when patients have a little bit of an infection in the wound, and this also helps create an incisional wound hernias. So this is the device, and I know it looks complicated, but I promise I have a slide further on that is going to explain it. And we put it on the patient, and we place the suture within the eyelets that you see over there. It's very easy to handle, and it helps us relieve the tension of the abdominal wall. I think this is the best slide ever because it explains what is happening with the device. When you have a shoe that has no eyelets, your laces can tear the shoe up. And when you have eyelets, when you have eyelets, it'll protect the shoe and it won't tear. So the device does the same thing, and it distributes the tension. This is an actual view of a porcine model, and you can see that the post is a little bit. You see the post here, sorry about the. Usually you could in the slides you can see the PDS suture that's going around here. And you can see that the tension is distributed within the device and not through the fascia itself. So what we did is we did a study. We included patients that were 18 to 75 years of age. They were scheduled for oncologic open procedures. We excluded those that were set to have a palliative procedure and that had a previous ventral hernia repair or had infection at the current surgical site. And the endpoint that we looked at was an clinically intact abdominal wall at 3, 6, and 12 months. Our secondary endpoints were the radiologic examination of the abdominal wall, pain, quality of life, and obviously device-related adverse events. I want to say that we had a median age of the median age was 56 years of age. We had five male patients, 10 female patients, and the BMI was quite broad, between 17 to 37. Most of our wounds were class 2 CDC classification, and the ASA classification was, in most of the patients, it was a class 3. I know that you might think that we cherry picked these patients because it's a feasibility study. We're trying to gather the best data, but we did not. So two of our patients were HIPEC patients. We had 5 patients that were set to have post-operative adjuvant chemo. So these are risk factors. Like you can get like the sense of how these patients had severe disease. Also, we had this was an interesting case. One patient had post-operative AMI, was put on full anticoagulation, developed a hemoperitoneum, and we had to reoperate the patient. It was a case that we learned a lot because we only had to cut the PDFs, get into the abdominal and the abdomen again, take out the hemoperitoneum, and we were able to close the abdominal wall with the same device that we used a couple of days before in the surgery. So, and we had 2 patients with recurrent cancer, metastatic progression, and death. And then just to show that we definitely did not cherry pick this patient, we try to show like real life patients in this study. So the primary endpoint, 14 of 15 patients, that's a 93% rate, had an intact abdominal wall at 1 year, so a 7% clinical hernia rate. That if we take a look at how like the patient characteristics, we would expect to have a 40% hernia rate in these patients. For the secondary endpoint, we have out of 13 patients we did images at 1 year, 92% of them had intact abdominal wall closure, and this is where it's very interesting. The radiographic hernia rate was only 8%, and the interrectus distance of intact participants was from 0 to 19 millimeters, but 7 of 12 had 0 millimeters. So we had a great response. This was amazing. I know it looks like a complicated slide, but I'm going to try to shorten it. So we have the visual analog scale from discharge, 1 month, 3 months, 6 months, and 12 months. And the medians were 0.5, 0, 0, 0, and 0, the median for these cohorts. It was amazing to see how this distributed the tension in patients in our, like when we compare it to our historical cohorts, we're having less pain. This is an image example, and you can see the interrectus distance is 0. This is 160 days after surgery, 160 days. Device-related adverse events, we had no adverse events that were related to the device. The device could possibly have contributed to 1 skin dehiscence with intact fascia and 2 superficial wound infections. But I think, to be honest, in the long run, we think we could have avoided those if in certain scenarios, and I don't think they were related to the device, to be honest. Because these were high-risk patients, high-risk operations. Most of them had abdominal GI resections. It was like a cohort of patients that had major oncologic and abdominal procedures. The expected hernia rate, as I quoted before, it would be around 41%. We only had a 7% clinical hernia rate and only 8% radiologic hernia rate in the study. So it was very low hernia rate. Excellent patient tolerance. No participants complain about palpability. The lowest BMI is 17. Like in the long, you can see the patients when they had their follow-up visits. The device will tend to disappear within a year, and even though you could feel in the first month the device, for some patients they had no pain whatsoever and no complications related to that. The question of there's this question of pain reduction that we have to keep on studying this, but what we saw is there is a difference in pain for these patients, no directly related adverse events to the device, and the SSIs were possibly related to the device, but it was interesting to see even in the patient with a hemoperitoneum, the device remained intact and was not required to be removed, even though they had the knee infection. That was it. Thank you very much.
Thank you so much. We'll take any questions. Anyone in the audience have questions?
I have a question, actually.
Yeah.
Sorry. So, thank you for sharing that presentation. You know, those are really excellent results. And even though you said they had low ASA, I'd argue that maybe the procedures that they were undergoing and the subsequent therapy makes those patients a high-risk population as well. But can you tell us a little bit about the device itself? What is it made of? I noticed you could see it on the CT scan. And in terms of patient selection, are there maybe patients that would not be good candidates for this if we were to introduce it more broadly?
No, it's an excellent question. So it's made you can take a look at it at the booth the App Solutions has here, and I encourage you to do that. The device is it's biomaterial that's bioabsorbable, so it's a conglomerate of things, and it will disappear in the span of 10 to 14 months in all of the patients. None of the patients had a palpable or a device that was seen in the scans when you did the scans after 14 months. I do believe that, to be honest, I think we kind of push like the device. I'm going to explain myself. Maybe I'm not using the correct words. I think we try to do patients that were high-risk patients that could really benefit from the procedure. And we did high-PEC patients. So it's not that we were trying to pick those with the like on the low-risk profile. I really don't see any, I don't see any contraindications to the device, to be honest. We didn't remove them when we had infections. We didn't remove them when we had to reoperate. And the benefits that we saw in our cohort were immense, to be honest.
Great, thank you so much. All right, next we'll welcome up Dr. Diego Lima, postoperative outcomes of concurrent paniculectomy and ventral hernia repair, systematic review and meta-analysis. And again, there's a QR code in the middle of your tables for voting for the best paper.
Hi everyone, my name is Diego. I'm a PGY free at Montefiore, New York. Thank you for this incredible opportunity. Today we're going to talk about one of our studies, this meta-analysis comparing concomitant paniculectomy to open and ventral hernia repair versus open ventral hernia repair. These are all disclosures. Most of our team is not that cool, but Dr. Mausch has his disclosure outside this submitted study. So basically, we know ventral hernia repairs often performed in patients with obesity, with painless, and we know that the paniculectomy improves cosmetic outcomes, but it can also increase complications, wound morbidity, and seroma, SSI, SSO. So it's still unclear, and this is the first, this actually the second systematic review and meta-analysis that evaluates the concomitant paniculectomy to ventral hernia repair versus just the ventral hernia repair. So that's our main objective, to do this systematic review and meta-analysis to see postoperative complications in these two groups. Eligibility criteria, we had RCTs, we had also observational studies, prospective, retrospective with propensity score matching adult patients, comparing open ventral hernia repair with simultaneous paniculectomy with just patient with the open ventral hernia repair exclusion. Studies that had overlapping populations and that didn't have the outcomes of interest. We looked at those databases, PubMed, Web of Science, Scopus, Cochrane, studies that were published until April this year, and we look at these outcomes: recurrence, readmission, reoperation, seroma, surgical site infection, SSO, skin necrosis, wound dehiscence, obviously operative time, length of stay. So applying our inclusion/exclusion criteria, looking at those databases, we ultimately included 13 studies. So looking at our baseline characteristics of the studies, I wanted to point out the studies we have few RCTs. We have two RCTs. Most of the studies, they are observational studies, and we also can see 4 studies with propensity score matching that, going to balance for the baseline characteristics of these patients. So you can have kind of similar groups despite you doing like an observational study. Also, if you can take a look at the last 2 columns, you can see, and these are already the limitations of our studies, like there are different techniques for paniculectomies being performed. We have different specialties also performing these paniculectomies, and also the lack in the technique for the surgical technique for the ventral hernia repair is one of our limitations. So when we look at the recurrency studies, the recurrency rate that the study is included, we see that the relative risk, it favors the paniculectomy plus ventral hernia repair compared to the open, just the open ventral hernia repair. Surgical site infection, on the other hand, we see that the patients that had the paniculectomy they have a higher risk of surgical site infection compared to just the patients who just had the ventral hernia repair, which kind of makes sense. Same thing for surgical site occurrence. The relative risk is 1.5, and it favors just the ventral hernia repair with no paniculectomy. Skin necrosis is the same thing, risk relative 2.9, favoring the ventral hernia repair compared to the paniculectomy, the associated paniculectomy. Reoperation also, high rates of reoperation, higher likelihood of having a reoperation if you had both procedures combined. Length of stay, it favors the ventral hernia repair. It's higher with the patients that have the concomitant repair, but this was not statistically significant. You see the confidence interval go from 0.4 to 1.4. So the limitations of our study, we have no details on the surgical technique for this open ventral hernia repair. You know that we have a bunch of retrospective studies. We have some with propensity score matching to balance these groups, but it is still a limitation. We also have this heterogeneity in how they perform these paniculectomies, and one of these studies had a larger sample compared to the others, and they had high weight, especially on recurrence. And then even when we do the sensitivity analysis and we remove this study, we can see that there was no difference in recurrence between the groups. So we know that this concomitant paniculectomy, you can have a lower recurrence rate, but you're gonna have also you can have high rates of wound complications. So the decision to do it, to not to do, should be shared with the patient, should be tailored, and patient should know the surgical risks that come and the costs with the procedure, with the concomitant procedure. Thank you so much for this opportunity, and I'll take any questions.
There's a microphone in the middle if you have any questions, or you can just ask your question. We can hear you.
Lower with just with maybe removing the excess of fat and skin, it could help with the core, but I don't really have a theory for that. Also, when we remove this study with the biggest sample, we found no difference, and we only included studies that had at least 1 year follow-up for that. So it's still something that we need more studies to really evaluate if decrease or not recurrence.
Great.
Thank you.
Thank you.
Our next presentation will be from Dr. Patel, and we'll be talking about laparoscopic repair of umbilical with inguinal with femoral hernia.
Good afternoon, everyone. Myself, Dr. Vishakha Patil. I'm from a small town in India, Nashik. Today I'll be presenting a video on laparoscopic E-tip RS for umbilical hernia with inguinal with femoral hernia. It's a three-port bottoms-up retrorectus dissection technique. So, as per the Egber et al., he has mentioned in his paper that multiple hernias, although uncommon, are not such a rare entity, and open hernial repair for such patients is going to be painstakingly difficult from point of view of the patient because it will require multiple surgeries, multiple settings. The post-op recovery will be delayed, prolonged analgesia will be required, etc. And since the advent of minimally invasive surgeries, such cases are becoming more and more easier to treat and also better for the patient. So today I'll be presenting a case of 65-year-old male who presented with pain and partially reducible swelling at umbilical region with dagging pain near right inguinal region since 1 year. He had a past history of urethral stricture for which he underwent surgery 6 months ago. On clinical examination, we did find umbilical hernia, but there was no appreciable cuff impulse at right inguinal region. On USG abdomen, the umbilical hernia diagnosis was confirmed. And USG inguinal region, although we did not find any appreciable impulse, showed a small reducible inguinal hernia. So we planned a laparoscopic E-tip RS procedure for this patient. This is the clinical photo. This is our standard port position. We usually go for a little higher 10 mm subcostal trocar, but since this patient also had an inguinal hernia, we went ahead and put the trocar a little down. Subsequently, the 5 mm trocars were also a little down than the usual position. With the red, you can see the umbilical and the inguinal hernia marked. So going ahead with the video, a standard retrorectus entry was taken and extraperitoneal space dissection was started. We cut the arcuate ligament for enhanced view. Traditionally, our protocol is to go through a 10 mm subcostal camera trocar for epigastric crossover. But since this patient also had an inguinal hernia, we went ahead with a bottoms-up retrorectus dissection, wherein we went from below upwards, as you can see in this video. Continuing our dissection from below upwards, we reached the umbilical hernia defect. As you can see, this umbilical hernia defect sac was open. The contents were reduced. Gentle external pressure was applied by a surgical assistant from outside. And with minimal traction, we reduced the umbilical hernia contents. After reduction of the umbilical hernia, we continued our dissection in the cephalad direction by cutting the posterior rectus sheath. Here you can see we are cutting the posterior rectus sheath and the falciform ligament is coming into vision, which was taken down for further visualization of the posterior rectus sheath. This is the falciform ligament, you can see, which was taken down for posterior rectus sheath visualization. Here you can see the umbilical defect as well as the differentiation between the rectus abdominis muscle, linea alba, and posterior rectus sheath. Continuing our bottoms-up retrorectus dissection, we are separating the posterior rectus sheath from the rectus muscle for sufficient retrorectus space creation. After separating, we shifted our camera port to the middle position. We used a 5 mm port for better visualization through the middle port. You can see the linea alba at the top in the midline. Further ahead with dissection, this is the peritoneal defect. Then after clearance, we went ahead with in the inguinal region. You can see the shiny Cooper's ligament. Then we went ahead to dissect at the deep ring. You can see the inferior epigastric vessel at the roof. Medial to the inferior epigastric vessel, we saw something going inside the femoral ring and hence decided to dissect there a bit. As we pull down the periperitoneal fat, you can see the iliacs coming into vision and we realized that the patient had a femoral hernia. So we decided to go ahead with dissection of femoral hernia, which was not picked up preoperatively either on imaging or on clinical examination. As we are dissecting the femoral hernia defect. You can see medially there's Cooper's ligament. At the roof, we have the inferior iliac vessels. The laparoscopic instrument pointing the indirect, direct, and femoral triangles. Cooper ligament can be seen medially. The dissection at the femoral ring. Superior to it, we have the iliopubic tract and the site for direct inguinal hernia. Then the inferior iliac vessels. Lateral to the iliac vessels, you can see the direct inguinal hernia site. Once we cleared all the contents from the femoral ring, you can see the anatomy depicted. The conjoint and the interfoveal ligament, the Henle's ligament. After completing the dissection at the femoral ring, by clearing all the adhesions, taking the extra lesions down, we went ahead to dissect at the deep ring. A gentle traction counter traction technique is used to dissect at the deep ring. We found a lipoma of the cord at deep ring, which was carefully dissected and reduced. And then we went ahead with dissection of the triangle of doom. As you can see, the lipoma of the cord getting reduced. Then we went ahead with dissection of the cord structures. You can see the cord structures retracted medially. We went ahead with dissection. Slightly medially, you can see a thread-like white structure coming into vision, which is the obturator nerve. Then we went ahead with dissection, remaining dissection of the cord structures. You can see the wasp drop down medially and the gonadal vessels laterally, demonstrating the triangle of doom. We cleared the space further for any adhesions. You can see all these anatomical landmarks clearly now. We decided to do a limited TAR in this patient so that the mesh would not tent and there'd be sufficient space for flat placement of the mesh. So we are doing the limited TAR. Then we went ahead for closure of the umbilical hernia defect using a barbed non-absorbable suture. The patient also had slight divarication, but since he was not symptomatic, we went ahead with just the closure of the umbilical hernia defect. By using the same suture material, we closed the peritoneal defect as well. The peritoneal defect closure was easy and tensionless. After closure of the defect, we kept a 30 by 25 centimeter mesh covering all the defects. A drain was kept. The procedure went uneventful and the patient was discharged on post-operative day 4. So taking this opportunity to share our experience of treating such multiple hernias in single stage surgeries, we have performed over 13 umbilical with unilateral inguinal hernias, 4 umbilical with bilateral inguinal hernias. That says umbilical with incisional, umbilical with epigastric, umbilical with inguinal with epigastric hernia. Particularly one special case of acquired abdominal intercostal hernia with diaphragmatic hernia. These are some of the pictures. On the left side, there's the umbilical with incisional hernia. On the right side, we have the acquired abdominal intercostal hernia and diaphragmatic hernia of the same patient. So by far, we have performed around 37 multiple hernia surgeries, out of which 24 were performed with laparoscopic E-type RS procedures. 8 of them required a concomitant transversus abdominis release. We performed 2 scolar procedures and 2 open sublevit TAR and 1 anterior component separation. In terms of patient outcomes, only 1 patient by far has had a inferior epigastric vessel injury, which was successfully tackled with a vessel sealer. 1 patient did develop posterior pulmonary atelectasis, which was managed successfully in the ICU. 1 patient required prolonged analgesia for about 3 weeks. The average post-operative stay for patients is around 4 days. 1 patient developed seroma, which was noted on 15 days follow-up. And there was no recurrence as of now on an average follow-up of 5 months. So concluding that laparoscopic ETAP-RS is a feasible process for addressing patients with multiple hernias. It prevents the need for multiple surgeries, multiple incisions, delayed recovery, and prolonged analgesia, etc. Thank you.
Any questions from the audience? Okay, great. For the sake of time, we'll move on. Great presentation. Thank you.
Thank you.
Our next speaker will be Dr. Bindal, presenting a study comparing the operative outcomes of ETEP retrorectus access, laparoscopic, and robotic-assisted ventral hernia repairs. Again, also eligible for the Best Paper Award for the QR code in the middle of the table.
Thank you, chairpersons, for inviting me and the opportunity given by AHS. So we're going to basically talk about this study where we compared our experience of robotic and laparoscopic ETAP approach for ventrals. So, right, so we do laparoscopic as well as robotic ETAP approach in our practice, along with some IPOMs and some open cases. And okay. So we started doing retrorectus repairs in 2017 and started robotic ETAP retrorectus in 2018. And we have been using SI for first 3 years and then XI from 21 onwards. So we looked at our cases at Max Hospital in Vaishali and Patparganj. Retrospective chart review was done after IRB approval was obtained from June 2021 to October 2023. So almost 2 years, 3 months. All patients who underwent retrorectus repair using ETAP approach were included. They were basically, if they were primary hernias, if the hernia defect was more than 5 centimeters, then we chose this approach, or incisional hernias or recurrent ventrals underwent a ETAP retrorectus repair. Patients with concomitant procedures were excluded from the study. And we looked at the demographics, the body mass index, the comorbidities of the patients, whether the hernia was primary, incisional, or recurrent, the defect size, the mesh size, operative procedure and duration, pain scores at 6 hours, 24 hours, 14 days on a numerical rating score, analgesic usage, quality of life at 14 days, and complications and readmission rates within 1 month. Recurrence rates were looked after from 6 months to 2 years, depending on the duration. So minimum of 6 month recurrence rates was there. So this is a short video which shows a technique of retrorectus repair. I think it's a 3-port technique with a robotic system, which is shown in this small video. I'll just forward this. This is an unedited video actually for, so typical duration is around 20 minutes. Typical duration is around 80 minutes. So this is 20 minutes of 4x speed. This is at 4x speed that you're seeing it. So this is a crossover, a superior crossover is done. And we always keep a small gauze space inside. And this is extending the space, going down. And this is the hernia sac, reducing the contents, taking it down, going to the cave of Fletzius. It was around a 4 centimeter hernia. So this is the entire dissection. And then we close the posterior defect. So we try to save as much peritoneum as possible, try to save the sac. And then we close the anterior defect. We run the entire linea alba from below upwards. And this is the umbilical defect, which was closed, and then the divarication was closed all the way up. And then we placed in a macroporous polypropylene mesh. We don't put in any drains, and this would complete the procedure. So we looked at 120 cases, and there were 73 robot-assisted cases and 47 laparoscopic cases. The demographics were pretty much similar. BMI was similar, so not much difference there. This is a chart showing the primary versus incisional rates. So in robotic ETAP repairs, you can see that the percentage of primary and incisional are similar. The overall study group had much more, around 70% incisional hernias and around 25% primary hernias in both the groups. But when you look at the recurrent hernia rates, the recurrent hernias were much higher in the robotic subgroup. So 31% of robotic ETAP were recurrent. In laparoscopy, 17% hernias were recurrent. So the overall operative outcomes were, these are the procedures listed. So in the robotic space, we did 61% reef stopa repairs. In laparoscopy, we did 36%. It was statistically significant. Unilateral TAR was performed in 34% of robotic cases and 44% laparoscopic. And bilateral TAR was done in 3 robot cases and 9 laparoscopic cases, so 19% of laparoscopic cases. The total operative time was shorter in the robotic group, 152 minutes versus 194 minutes. You can see the area of the hernia defect was much larger, 79 centimeters square in robot group versus 32 centimeters square in the laparoscopic group. The length and width of mesh was more in, it was kind of similar. So this was the overall operative outcomes. And then we looked at the pain scores, and there were some lower pain scores for the robot group. But we tried to explain as to why are we seeing this difference in the robot and laparoscopy group. And that's when we decided to subgroup them on the basis of hernia defect size. And we look at the width of the defect, because typically the width of the defect would decide whether or not a posterior component separation is needed or not the length. So we divided the patients into 3 subgroups. One was less than 7 centimeter wide, in which robot had 32 patients, laparoscopy had 35, 7 to 10 centimeter wide, and more than 10 centimeters. So all the more than 10 centimeter W3 hernias were in the robotic group, because we tend to do all those complex hernias robotically. And we just did a retrospective chart review, so there was none done laparoscopic. And you can see the numbers here as well in this chart. So, and then we compared the outcomes there. So in less than 7 centimeter wide hernias, in robot, we never required a TAR. So 100% of the patients did with ETAP-RS, while in laparoscopy, 42% of the patients required a single unilateral TAR. So this was a significant finding. That led to lower operative time in the robotic subgroup. And the overall length and width of mesh was more in laparoscopy because of more TAR done. And the quality of life was, slightly better in robotic group, statistically significant. The pain scores, again, this red line is laparoscopic, the blue line is robotic. I don't know if you can see it well, but this is pain score is much less in robot group, and it's basically because of less posterior component separation. Then we looked at 7 to 10 centimeter wide defects, and in robotic subgroup, almost 40% patients required a unilateral TAR here. And in laparoscopy, there was none which was done without a TAR. So every 50% required unilateral, 50% required a bilateral TAR in laparoscopic subgroup in our hands. And in robot, 13 were done with just reef stopa. So this was again a difference. So similarly leading to lower pain scores in the robot subgroup at 14 days, basically. Before that, there was hardly any difference in the pain scores. Then in the W3 arm defect, more than 10 centimeter, the robotic had 16 unilateral TARs and 2 bilateral TARs. Laparoscopy had no case in this. And then we compared basically this subgroup, more than 10 centimeter with 7 to 10 centimeter subgroup of laparoscopy. And we found out that in laparoscopy, even in a smaller defect size, the TAR rates are higher than robotic. So basically, there are very few studies that compare lap versus robotic retroactus repairs. We had more complex hernias in our robotic subgroup. This is the only study which has been published till now, which was by Richard Liu, which had robotic subgroups had larger defects. And I've already said that because of lower TAR rates, we had less pain scores. The limitations are it's a retrospective single center study, heterogeneous patient cohorts, and absence of long-term follow-up was there. I think, so we concluded in this study that robotic approach may have a lower need for TAR compared to lab. The pain scores are less and quality of life is better, and larger multi-center studies will bring out better data. We are doing this abdominal wall reconstruction surge meeting in Chennai, and we would be happy to have you there. Thank you.
Any questions from the audience? Yes, question here.
I think I was mentioning the TAR rates in robotic, not the recurrence rate. So there was no recurrence. Yeah, because this was a short-term follow-up of 6 months. There was no recurrence in any group. We are looking at the component separation rates.
I think he meant those were recurrent hernias.
Recurrent
Yes,
hernias.
the
Okay.
demographics, I think, because I was thinking,
Okay,
yeah,
okay. All right.
that's what you meant.
Yeah.
Did you have a question?
Yeah, I think we have started that prospectively now. Looking at these results, it needs imaging will be more academic, clinical. We are trying to bring back patients to office after a year and getting them scanned also. But then it's a part of a prospective trial. So for this study we didn't do it. It was just a retrospective chart review. So it was more about the first month perioperative phase after this surgery, not at a year. Thank you.
All right, thank you. Our next Our next presentation is about the correlation between obesity and pneumoperitoneum in initial trocar access for ETIP, presented by Dr. Bast.
Good afternoon, everybody. Today's topic is correlation between obesity and pneumoperitoneum in initial trocar access for ETAP in hernia repair. We generally use a steel trocar, so this study is based on steel trocar only. So this is my biggest hospital in tribal India. This is not my hospital, but I'm working in this medical college in rural and tribal India. Though laparoscopy has lots of advantage, it still carries the disadvantage of cost. Is the biggest factor in rural and tribal parts. This is my disclosures. These are my some few patients who are daily wages workers, resides in hilly area and have high cultural values. So their socioeconomic strata is more important in working in rural and tribal areas. The monthly income of 80% of these individuals range between $50 to $200. And these Optivu trocar cost is around 100 to 200 US dollars, and sometimes the cost goes beyond $2,000. This is the preferred method in any ETAP initial access worldwide, advantage being direct visualization. Uh, Consider these tribal and rural individuals. Our institute come up with some few innovative ideas so that patient comes to our hospitals. We have quoted this much cost for the poor patients. In many rural tertiary health centers where the majority of patients come from the low socioeconomic backgrounds, the use of steel trocars is more common. Steel trocars being more affordable and reusable are favored despite not offering the same level of visualization as Visiport, but safety features as optical trocars. However, their use demands greater skill and experience from the surgeon to minimize the risk of injury during insertion. And these steel trocars cost only about 100 to 200 US dollars and can be used for 100 to 200 patients. Initial trocar access in obesity is a big challenge, that too it's bigger challenge in ETAP surgeries. What if any surgeon see this in ETAP initial access trocar site? So why pneumoperitoneum is a problem? Because extra trocar or varus needle puncture required to deflate the pneumoperitoneum, less dissection space in retrorectus area, more chances of peritoneal rents, more chances of bleeding, increased operative time, and more post-operative pain. Aim of this study is to determine the correlation between obesity and pneumoperitoneum during initial steel trocar access for ETEP hernia repair. My materials and methods are: this retrospective observational study was conducted at a single institute and included all patients who underwent laparoscopic ETEP or ETEP RS hernia repair at our center between March 2023 and April 2024. Pre-operative data were collected on patients' demographics such as name, age, sex, height, weight, body mass index is calculated. The BMI was calculated by dividing the patient's weight in kilogram by square of their height in meters. Statistical analysis: the data were analyzed using descriptive statistics. The Chaiker's test was employed to evaluate the association between BMI categories and the occurrence of pneumoperitoneum. A p-value of less than 0.05 was considered statistically significant. This is my contingency table. We have divided BMI categories less than 25, 25 to 29.9, 30 to 34.9, and greater than 35. In less than 35 BMI categories, in total 53 patients were operated, only 2 patients developed pneumoperitoneum. In 25 to 29.9 BMI category, 77 patients were operated, out of which 7 patients developed pneumoperitoneum. In mildly obese patients, 30 to 34.9 BMI, out of 25, 15 patients developed pneumoperitoneum during the initial trocar access site. And in morbid obesity, all 3 patients developed pneumoperitoneum during initial trocar access. So these are my observed and expected frequencies of pneumoperitoneum by BMI categories. Since 57.15 is much greater than both critical values, that 7.8 and 11.3, we conclude that there is statistically significant association between BMI categories and the occurrence of pneumoperitoneum at both the 5% and 1% significant level. Again, you can appreciate when there is a BMI more than 35, the pneumoperitoneum chances are high by a graphical demonstration. Results: a study included total 158 patients. Males were 113, that is 71.52%. Females were 45, that is 28.48%. The mean age of the participants was 48.5 years, ranging from 25 to 72 years. This is again a percentage according to BMI. In less than 25, only 3.77% patient developed pneumoperitoneum. In 25 to 29.9 BMI category, 9% patients developed pneumoperitoneum. In 30 to 34.9 BMI, 60% patients developed pneumoperitoneum. And in morbid more than 35 BMI, all 100% patients developed pneumoperitoneum. This is again graphical representation. Discussion: the observed rates of pneumoperitoneum in our study was 17.08% overall, with 64% in obese patients and 6.92% in non-obese patients, reflect a significant difference between the two groups. Coming to what PubMed or what other journal says, this is one study by Shah Mohammad Yunus, surgical outcomes of laparoscopic total extraperitoneal repair, inguinal hernia repair, compared with lichen stents open surgery. In his conclusion, he said that in the laparoscopic tape group, the main intraoperative complication was the accidental creation of pneumoperitoneum, which occurred in 13 cases, that is 14.7. In our studies, we encountered 17%, and that is managed by various needle insertion. In second study, an observational comparative study of the impact of accidental pneumoperitoneum in understanding the learning curve of totally extraperitoneal and extended totally external inguinal hernia repair. In this study, he evaluated the learning curve only, but not the obesity. Results: 10% of the procedures in the tape group and 6.7% in the e-tape group required various needle use to manage accidental pneumoperitoneum. This is again a one study, a trocar insertion in enhanced view repair in inguinal hernias. Dr. Rahul Mahadar has mentioned this study. According to his study, he developed pneumoperitoneum only during dissection of the hernia sac and not during the initial trocar access. Again, one more study, extraperitoneal laparoscopic approach in inguinal hernia. He mentioned he operated 493 consecutive patients, but he did not develop any pneumoperitoneum or any complication. Must be a God-gifted hand to this surgeon. Again, a last study, laparoscopic ventral hernia repair in patients with obesity should be scared, but he did not mention about pneumoperitoneum. He mentioned about the bowel injuries in these studies. So our study findings indicate a positive correlation between obesity and the development of pneumoperitoneum during initial trocar access for ETEP hernia repair. Since the study was conducted at a single institute by a single surgeon, factors such as technical variability and inexperience contributing to pneumoperitoneum were not considered. The study findings for each patient were documented after consultation and discussed with radiologist about some data regarding the thickness of the posterior rectus sheath, distance from the skin to the posterior rectus sheath, and distance of the skin from the anterior rectus sheath. Limitations: relatively small sample size in each group might limit the generalizability of the finding. A larger sample size could provide more robust and statistically significant results. Conclusion: again, obesity emerges as a significant predictor for pneumoperitoneum formation during initial access for ETEP hernia repair, which can impact the overall difficulty and outcome of the procedure. Surgeons performing laparoscopic hernia repair in obese patients should be aware of this positive correlation and take appropriate measures to mitigate associated risks. We advise this study during training procedures, because some residents may get a chance to operate on obese patient and may land up in pneumoperitoneum, and after pneumoperitoneum he may not be able to complete the surgery. So before giving to any residents or fellow these surgeries, obesity should be considered. Appropriate measures from our side are detailed personal discussion of CCT with radiologist, meticulous dissection for initial access, detailed demonstration of subcutaneous fat, anterior rectus sheath, posterior rectus sheath and muscle, low BP at the site time of initial access, if and possible to avoid bloody field, proper use of tissue retractors like long angle bladed or pediatric Dewar retractor, and use of OptiView trocar whenever patients are affording. These are my references. Thank you.
Any questions from the audience? I have a question. Did you modify the location in which you placed the trocar initially based on their BMI? Because as you know, the obese patients are more likely to have a greater rectus
We do not modify our initial trocar axis according to BMI, but we modify the initial trocar according to the site of the hernia. If we combine the umbilical hernia with inguinal hernia, then our initial trocar axis will be on below side. If we are doing epigastric and umbilical hernia, then our first choice will be a subcostal trocar.
Okay, thank you. We'll invite our last speaker up, Dr. Ponce Leon, discussing results and analysis of the implementation of an abdominal wall hernia service in a public university hospital in Brazil, also a candidate for a best paper in the QR codes in the middle of the tables.
Good afternoon. Thank you so much for the opportunity. Thank you, doctors. My name is Fernando Ponce Leon. I'm a general surgeon from Rio de Janeiro, Brazil, and I'm here to present results and analysis of the implementation of abdominal wall hernia service in a public university hospital in Brazil. There is a reason why we are here. We are here to discuss about hernias. So we know that hernias, ventral hernias, inguinal hernias are a super common pathology in our routine, and we have an incidence of ventral hernias that are around 10 to 40%, depending on which site and which place you are studying. If you want to see the reason why you get that hernia, if it's a ventral primary hernia, if it's an incisional hernia, the percentages, they vary. But normally, midline incisions and transverse incisions are the main cause of this pathology to appear. And of course, this also has a cost. In the United States, around 600,000 ventral hernia repairs are done yearly, with around $10 billion being spent with the treatment of those pathologies of those patients. And then when we translate that to Brazil, we discovered that we don't have that data. We don't know how many patients we are operating, and we don't know how much we spend with them. So the idea of our study, and mind you, I'll be telling a little about our hospital and our scenario to you understand why the reason that we did this paper. This is a prospective observational single center study carried out with patients operating on ventral hernia from January 2019 to December 2023, analyzing anthropometric data and outcomes. This is a university hospital that doesn't have any kind of program happening. We just have 4 treatments of ventral hernias, high weight meshes, microporous meshes that are the cheapest ones, and stitches, normally Prolene and Vicryl, but basically we don't have any kind of ultimate resource. And from 2019, 20, and 21, we didn't have any kind of abdominal program. We started our program in 2022. And in 2020, we were hit with COVID. So the numbers here try to demonstrate, although it's a weak study in cases of the size of the numbers of patients analyzed, that there are difference when you analyze, when you begin an abdominal wall program. So here are our results. We have 201 males and 150 females been operated with a length of stay of 2.44. We have done 99 primary repairs, 197 onlay repairs, and 38 sublay repairs. When you look at the clavia-dindo complication scale, you have, in the most general cases, 83 patients with clavia 1, and we are going to analyze this data later. And we have 30% of complications between the first 7 days, 4% of complications between the 30 days, and only 0.88 recurrence, only 3 recurrences. And then you think to yourself, wow, you have 340 patients analyzed and only 3 recurrences. At least this hospital is good in doing the surgeries in those patients. And the problem is we don't have a surveillance program happening from 2022 prior. So we now are analyzing our patients, and now we are finding the recurrences. So it's a number that we imagine that is going to be similar to what the literature is saying in the next few months. Here is our groupment of EHS analysis of the patients. We can see that we have the great majority being M3 hernias that are the most common hernia, and you have some flank hernias and some M1 and M5 hernias. But when you analyze year by year, you see that prior the opening of our service, we weren't doing any kind of flank hernias. We mainly did the normal hernias. Those patients were been waiting to being operated for 5, 6, one patient specifically 8 years. So the necessity of having a specialized services taking care of those patients shows that you can make a difference even if you don't have enough money, even if you don't have enough technology. The size of the holes that we were fixing were only being charted in beginning 2022. After that, in the operation reports, there weren't the measure of the sizes of the holes that we were fixing. And here are the surgical techniques. There is just one heterorectus repair done in 2019 that it was done by me. In 2020, we were hit by COVID, so we did have a great fall down in the number of patients that were operated. In 2021, we started thinking about opening an ab wall program, and in 2022, we started with 11 retrorectus cases, and now was not the only surgeon doing the ventral hernia repairs. All other gen surgeons from our service, we have a service with 20 general surgeons, but just one dedicated to ab wall surgery. We're doing repairs also, and we were collecting that data as well. And when we look at the complications, we see that the most common, complications happen between the first 7 days, and we have hematomas and seromas as the main complication. And when you look at the years, you see that 2022 and 2023 were the years that have most complications. And you think, well, you shouldn't have opened the program then because you have more complications. But when you look back and see the number, oh God, you see the number of surgeries that were done. We did more surgeries in 2022 and 2023, so the percentage of complications were smaller in the years that we are starting doing our best. When we analyze complications by complications, you see that we have 2 deaths in 2022. And that's because we're starting to be referred by other public hospitals in the Rio de Janeiro. That we have a main problem associated with big ventral hernias. Those patients, they are not being taken care by the surgeons because it's not like cancer. You don't have that, and many quotes, excuse that the patient will die because of that disease. So the patients, they are being told by most surgeons in the city, that you have to live with that disease. So we are being referred as now as a main center in those patients that have super high BMIs, a lot of comorbidities, and they come strangulated and incarcerated. So we have been growing in the learning curve, and teaching other surgeons and residents how to do abdominal wall complex surgeries, and the complications are expected for this kind of institute. So as in conclusion, despite a small number of patients in the pandemic period during the observation interval, we conclude that the opening of an ab wall hernia service in a public university hospital brought benefits to postoperative outcomes with statistical relevance, observing a greater number of heteromuscular repairs with a decrease in the number of global complications and hernia recurrence. There's a need for observation, a longer observation interval that confirms the initial conclusions obtained. Thank you so much.
All right, excellent presentation. Are there any questions? I have a question, actually. And I think your presentation really highlights the importance of having these patients being taken care of by specialists with expertise in this field. Is there any thought about moving into the prevention space? Specifically, I know that some hospitals have like closing teams or dedicated teams of abdominal wall specialists who will, do combo cases with other surgeons or other specialties in the hopes that maybe they can prevent the formation of hernias in the first place.
It's a super big and super old hospital that we have in Rio. So we have, as you can imagine, super old surgeons also, that the teaching ability, the teaching skills are one of the greatest challenges that we have. For sure, it's important to talk about prevention, not only prevention, but pre-op optimization of those patients. So not operating them with smoking happening, with high HB1ACs, turning down their BMIs, and to literally convince those old surgeons to do that is quite a challenge. I do believe that is super important, the prevention of the ventral hernias. We teach our students and our residents the principal guidelines of the AHS about small bites, small steps, and using the correct tension and the correct fascia to close it. But it's quite a challenge. I cannot be super pragmatic and tell you that it's going to happen and it's happening, but it's like the bird in the fire, with small drops of water as we can. Yeah.
Wonderful. Thank you so much. And thank you all for joining us today, and great work to all of the presenters.